What's up, TUMNAD lectures? In this video, we are going to be looking at what we call stroke volume. If you find it helpful at the end of it all, please make sure you like the video, comment down in the comment section, and please subscribe. Let's go ahead and get started. So now in the previous video, we looked at what we call the detail of what we call heart rate as also a component of what we call cardiac output. In this video, we are going to be looking at what we call stroke volume. So we'll go ahead and look at what we call the determinants of what we call stroke volume. Now, we need to first understand what is stroke volume. Stroke volume is the volume of the blood pumped out by the ventricles every single beat. Okay, volume of the blood pumped out by the ventricles every single kind of the beat. Okay, so now stroke volume is the volume of blood pumped by ventricles per heartbeat. Okay, so now that is a simplified definition of what we call a stroke volume. So now the question is, how do we calculate stroke volume? We have this beautiful kind of the equation that a stroke volume is going to be equivalent to what we call EDV minus what we call ESV. Now you may ask yourself, what is EDV and what is ESV? Now, when we talk of EDV, EDV stands for end diastolic volume. Okay, it stands for end diastolic volume. Okay, and then when we talk of ESV, this one stands for end systolic volume. Okay, it stands for end systolic volume. Okay, so now that is the meaning of those kind of the abbreviations EDV and what we call ESV. Now the question is, we need to first understand, how do we approximate these kind of the figures to come up with what we call stroke volume. Now let's have a look at this practical illustration of how we get what we call EDV and what we call ESV in a simplest kind of the practical. You need to have a look at this one by yourself. Okay, now this one here, let's first pretend for a minute that this one here is going to be representing our ventricles. Okay, and of course during what we call the cardiac cycle, the atria are going to be allowing 80% of the blood to move down to the ventricles passively, and they will contract to push the remaining 20%. That is something which everyone must know. Okay, the atria push the remaining 20% after the 80% moves down passively. Now we're going to be filling these now ventricles with air, but assume it is blood which is going to be filling the ventricles. Okay. Now my ventricles are filled up with blood. Now this volume of blood within these ventricles, before they contract, this volume of the blood is what we call the end diastolic volume. I want to repeat on this. The volume of the blood in these ventricles before they contract is what we call the end diastolic volume. Okay, so now this one here is what we call end diastolic volume, and on average it is going to be generally close around 120 to 140 milliliters. But for right now, I'm going to be taking 120 milliliters. Okay, it's going to be around 120 milliliters. Okay, so now this is the volume of the blood in the ventricles before they contract. Now, after they have relaxed and have been filled up with the blood due according to the end diastolic volume, is now their time to contract. And of course, when they contract, they'll be pushing out the blood. Now, let's contract them. They have now successfully contracted, meaning that after the contraction, not all the blood is going to be ejected off the ventricles. There is a specific amount of the blood which remains in the ventricles even after contraction. And that volume of the blood which has remained in the ventricles after the contraction, this volume of the blood is what we call the end systolic volume. Okay, so now that volume is what we call end systolic volume. And this volume on average is going to be close to around 50 milliliters. Okay, it's going to be close to around 50 mils. Okay, now if you subtract end diastolic volume from end systolic volume, we are going to be coming up with what we call the stroke volume. So now let's have just this simple mathematics. When you calculate very well, you are going to be ending up is what we call 70 mils every single kind of the bit. Okay, so now that is a simplest way on how you can come up with what we call the stroke volume, having known what we call end diastolic volume and what we call end systolic volume. At the back of your mind, I want you to know that even when the ventricles squeeze as if they have never squeezed before, they can never squeeze out all the blood. There is always that amount of the blood which remains in the ventricles even when they contract. And we call that one as what we call the end systolic volume. Okay? Now that we have seen how we are getting what we call the stroke volume, let's go ahead and see what are the determinants of what we call stroke volume, because it's very important to know what are the determinants of this kind of the volume of the blood which we are calling the stroke volume. Okay? So now let's take a look at what we call the determinants of what we call stroke volume. There are going to be three main determinants of what we call stroke volume. What are these three determinants? The first one is what we call preload. Okay, the first one is what we call preload, and then the second one is what we call the contractility. Okay, the second one is what we call contractility. Okay, and then the third one is what we call the afterload. Okay, the third one is what we call the afterload. These are the three main determinants of what we call stroke volume. So let's go ahead in detail of each one of them and see how it is affecting what we call stroke volume. We shall go straight forward and look at what we call preload. Okay. Now the question is, what is preload? Now, preload just simply means the degree of myocardial stretch. Okay, the degree of myocardial stretch, how wide the myocardium can stretch to accommodate what you call the venous return. Okay, so now preload simply means is the degree of myocardial stretch. Okay, how wide the myocardium can stretch to accommodate what we call the venous return. So now this preload is going to be exactly dependent on what we call the diastolic volume. In other words, end diastolic volume determines the preload, because we have said that end diastolic volume is the volume of the blood within the ventricles before they contract. Okay, meaning that preload is going to be dependent mainly on what we call end diastolic volume. Okay, and of course this end diastolic volume is going to be depending on how much blood comes back to the heart. Okay, and this end diastolic volume depends on how much blood comes back to the heart. Okay, and this blood which is coming back to the heart is what we call venous return. If you increase venous return, you're going to be increasing end diastolic volume, and of course if you increase end diastolic volume, you're increasing the degree of myocardial stretch, which we call the preload. Now the question is, how do we increase venous return? Okay, the question is, how do we increase venous return? Now, the following are the factors which promote venous return. I'm going to go a bit slightly faster because in the next video we're going to go into the detail of the factors which promote venous return. But for right now, I want you to trust me. The following are the factors that promote an increase in what we call venous return. Okay. And the first one is what we call muscular milking. Okay, what we call muscular milking. The second one is what we call respiratory pump. The third one is what we call sympathetic nervous system, which causes vasoconstriction, and this one is what we call venomotor. Okay, is what we call venomotor. Okay, and then another one is what we call the cardiac sanction. Okay, cardiac sanction effect. Okay, we shall go ahead and look what do I mean when I talk about cardiac sanction effect. And then another one is going to be the presence of what we call valves. Super very important, ensuring unidirectional blood flow in veins to come back what we call to the heart. And another one which is a bit somehow a bit minor, but is also super very important, is going to be what we call the gravity. Okay, so now all these ones are going to be ensuring an increase in what we call venous return. Now, if you increase venous return, you're increasing end diastolic volume. Once you increase end diastolic volume, you're increasing preload. It means that if you have an increase or greater kind of the myocardial stretch, these myocardial cells are going to be also contracting even more stronger to eject the blood coming out. And this one was explained by one of the great scientists called Starling, and he named it as Starling's law, meaning that the greater myocardial stretch, the greater the force of contraction. Okay, so now what does Starling's law say? Starling, Starling law. He says that the greater myocardial stretch, the greater the myocardial stretch is equal to greater contraction. Okay, what do I mean by this? That if you stretch this myocardium excessively, they will also generate an excessive amount of energy to eject that kind of the blood. The greater stretch, the greater contraction, and that one defines what we call the Starling zone. So now that briefly covers what we call preload. Let's go ahead and look on what we call the contractility as also a determinant of what we call stroke volume. Okay. So now let's briefly talk about what we call contractility. Contractility just means the contraction of what we call the heart muscles. But before you go into the detail, take a look at this one by yourself and see exactly what do I mean when we talk about what we call myocardial contractility. You need to have a look at this one by yourself. I want you to watch how the myocardium are going to be contracting. Now that you have seen what we mean by what we call contractility, now generally this kind of the contractility is also going to be determining how much of the volume of the blood will be ejected off every single kind of the beat. Now, what are those kind of the factors that really affect this kind of the contractility? And this kind of the factors which affect the contractility can either increase the contractility or even can decrease what we call contractility. And by doing all that, the volume of the blood ejected off the ventricles will be affected significantly, which is the stroke volume determination. So now let's go ahead and look at the factors which can affect what we call the contractility. Okay, we are looking at the factors. We are looking at what we call the factors which can affect what we call contractility. Now, the first one, which is super very important, is going to be what we call the drugs. Okay, drugs are going to be affecting significantly the contractility of what we call the myocardium. We have drugs which can increase the contractility, the force of contraction, and even also have those drugs which can reduce what we call the contractility. Now, those drugs which are going to be enhancing the force of the contraction, we have drugs like, for example, the butamine, we have drugs like the digoxin, we have drugs like atropine. Those ones are going to be increasing the force of the contraction. We also have some of those drugs which are going to be decreasing what we call the contractility, like for example the calcium channel blockers, the beta blockers. Those drugs are going to be aiming at decreasing the contractility of what we call the myocardium. By doing that, it is also going to be one of the determinants of what we call the stroke volume. Okay, sympathetic nervous system. And of course, when we talk about sympathetic nervous system, this one is going to be as a result of what we call release of what we call epinephrine and what we call epinephrine. Okay, and of course, this kind of epinephrine is going to be coming from what we call the adrenal medulla. Whenever sympathetic nervous system is activated, the adrenal medulla releases what we call epinephrine, which together acts on what we call beta-1 adrenergic receptors on the heart muscles, leading to an increase in what we call the force of what we call contraction. So now sympathetic nervous system also can affect what we call contractility. Another one is going to be what we call thyroid. Is going to be what we call thyroid hormones. Okay, and when we talk about thyroid hormones, we are meaning the T3 and what we call the T4. Now, How does this hormone affect what we call contractility? You know, these T3 and T4 hormones, they can enter into what we call the myocardial cells and stimulate the genes which increase in expression of what we call beta adrenergic receptors, primarily beta 1 adrenergic receptors. So now by the effect of these thyroid hormones, we are going to be having an extensive amount of what we call beta 1 adrenergic receptors. And if you have too much of the beta 1 adrenergic receptors and you have a lot of the norepinephrine and epinephrine, you're going to be increasing the strength of what we call contraction. Okay, it is such another beautiful thing. Okay, so now what other else can affect what we call contractility? We also have what we call electrolytes, or even what we call the ions. Iron can also affect what we call contractility. You have those ions which can significantly increase the force of the contraction, and you have those ions which can also inhibit what we call the contraction. Now, the first one, which can increase the force of contraction, is going to be high levels of what we call calcium. Okay, and those kind of the ions which can significantly lower what we call contraction is going to be an excessive too much of what we call of the potassium, and even also too much of what we call sodium ions. These ones can significantly inhibit the contraction ability of what we call the myocardium. If you have them in excess, this one will be inhibiting contraction of what we call the myocardium. Okay, so now these are the brief kind of the factors which are going to be affecting the contractility. And even another one which is a bit somehow minor is going to be what we call the what we call the glucagon can also significantly affect what we call the contractility. Okay, so now this briefly covers the contractility as also one of the determinants of what we call stroke volume. Now let's go ahead and look at what we call afterload. So now talking about the afterload. What is afterload? So now afterload just simply means the resistance the heart must first overcome to eject the blood of the ventricles. Okay, that is what we mean by afterload. That kind of the resistance the heart must first overcome before it ejects the blood of the ventricles into their respective areas. What do I mean by this? Let's first pretend for a minute I put blood in what we call the ventricles in form of air, and then we see exactly what do we mean by what we call the afterload. Now, my ventricles are now filled up with blood. But these ventricles, they have to push the blood into their respective areas. The left side will push the blood to what we call the systemic circulation, and then the right side will put the blood into what we call the pulmonary circulation. Now, let's first pretend for a second that maybe these valves, these kind of the aortic valves, maybe they are becoming a bit stenosed. And if they become stenosed, meaning that they are not going to be opening all that significant the way we want. It means that these ventricles, they will have to be squeezing with an extensive amount of energy to bypass that kind of the stenosis, the kind of the aortic semilunar valve. Meaning that this kind of the aortic semilunar valve is going to be increasing what we call the afterload. Okay, that is something which is super very important. So now we have seen what can increase what we call afterload, aortic valve stenosis. Now, let's first pretend for a minute that, for example, this one to be our aorta, and then we develop something like an atherosclerotic plaque. If we put something like an atherosclerotic plaque in this kind of the aorta, it is also going to be narrowing what we call the aorta. That one also is also going to be increasing resistance to the out movement of the blood of the ventricles. Meaning that the ventricles must even pump even more harder to make sure that that blood bypasses that area which has been narrowed by what we call the atherosclerotic plaque. Meaning that also atherosclerotic plaque can also increase what we call the afterload. Okay, another thing is that for example, if you have something like anything which can increase the systemic vascular resistance, especially in what we call the arterioles, that will also be generating an extensive amount of the pressure which will be backing up the blood back into what we call to the aorta. It means the ventricles also must squeeze it even harder to overcome this kind of systemic vascular resistance. Meaning that all these three kind of circumstances I have just talked about, they are going to be increasing what we call afterload. And if you increase afterload, you are going to be decreasing what we call stroke volume. Meaning that increase in afterload is inversely proportional to what we call stroke volume. Okay, it is such another beautiful thing. So now what have we said? We have said that afterload is the resistance. Okay, is the resistance the heart is the resistance the heart must first overcome must must first overcome to eject to eject blood. Okay, so now that is a simplified definition of what we call afterload, and we went ahead and looked at some of those kind of the factors which can increase what we call afterload. And we said that the first one is what we call aortic valve stenosis. Okay, stenosis, and then we have looked at another one as what we call atherosclerotic atherosclerotic plaques, which can occlude the aorta, increasing the resistance to out movement of blood from what we call the ventricles. And then the last one, we said anything that increase what we call systemic vascular vascular resistance. Okay, now even also anything that increase, for example, the pressures within the pulmonary circulation, or what we call the pulmonary hypertension, will also increase what we call the afterload, especially in what we call the right ventricle. Okay, so now a first one, which is a bit somehow minor, is going to be what we call the pulmonary hypertension. Okay, so now that briefly covers what we call afterload. And if you think whatever I have taught is making sense, is really adding to your benefiting, please, you can support me. And that one can be done by a couple of means. You hit the like button, comment down in the comment section, and please subscribe. So now in the next video, we are going to go ahead and finalize what we call the factors affecting cardiac output. We shall go into the detail of what we call venous return and look at the factors which promote venous return in great detail. And then we finalize what we call regulation of what we call cardiac output. Thank you very much for watching TUMNAD as always. Until we meet next time.